Good evening, everyone. I'm going to give everyone a couple of minutes to get signed in, and then we'll get started here shortly. All right, we'll get started here. Good evening, everyone. Thank you for joining us. We're excited to welcome you to tonight's webinar, How XTRAC Can Benefit Your Patients Clinically and Your Practice Financially. Tonight's webinar will run about an hour, and we'll leave some time at the end for a Q&A session. So feel free to drop your question in the Zoom Q&A box throughout the presentation. I'm pleased to introduce you to our speaker, Dr. Michael Nazareth, a board-certified dermatologist and president at Western New York Dermatology, and a longtime XTRAC provider. Dr. Nazareth will be walking us through the clinical value of XTRAC, sharing real-world insights on patient outcomes, and discussing the financial impact it can have on a derm practice. With that said, Dr. Nazareth, I will turn it over to you. Before we jump into the presentation, Dr. N, could you begin with a brief introduction, your background, your practice, and your experience with the XTRAC eczema laser?
Yeah, absolutely. Rob, thank you so much for the introduction. And everyone who's on this webinar, thank you so much for joining the call this evening. I know your time is valuable. So I'll try to give you some insights on both the, obviously scientific end of things and also the practice financials that go into this with patient selection to make sure this really becomes an excellent treatment, both for your patients and for your practice. So I'm located in Buffalo, New York, have a private practice out here that has grown quite a bit. We started working with STRATA and our XTRAC machine in 2017 and have grown quite significantly since then, and our usage continues to grow. We use it for psoriasis, but also for vitiligo and atopic dermatitis, and have seen really nice results with this. And obviously, ever since we've chosen this model and this partnership with STRATA, I can honestly say that both our patients and practice really have benefited from that immensely. So it's been probably like 8 years, almost 9 years now that we've been working with them, and hope to continue to use the device and make the most of it and really helping our patients and our practice. So with that being said, this is kind of about me. Been using it for 9 years here. A member of all the societies that I think most of you are part of too. So just a brief introduction to XTRAC here. It is a 308 nanometer excimer laser. It is FDA cleared for the treatment of psoriasis, vitiligo, atopic dermatitis, and leukoderma. And critically here, unlike some lasers, it is clear for the use of all Fitzpatrick skin types. So your African-American patients are very safe with this as well. Just an overall picture here, because the question is, who's a good candidate for excimer laser therapy, and are there enough patients to support this? This is a really large patient base. If you take those three big diseases there, psoriasis, vitiligo, and atopic dermatitis, that encompasses about 10% of the US population. So there's over 34 million people with these diseases. Obviously, probably atopic derm and psoriasis are bigger than vitiligo in that space, but there's a large number of patients that have these conditions, and these are people that are walking into your practice every day. And I will give you some tips on how you can incorporate this as a adjunctive therapy in addition to monotherapy, so that all your patients really can benefit from this. It's been clinically proven to be very safe and effective. It is covered by insurance, and that one is really big because it really minimizes financial burden on patients. There is also a copay assistance program that is run by STRATA that I will get into that further increases the financial benefit for your patients and also increases compliance. The sessions are very quick. You're probably looking at about 20 to 30 minutes per session there. In my practice, and this varies obviously on state, in New York State, the nurses in my practice can administer the treatment. So it's my nurses who are doing these treatments. And it can be a conjunctive device here. Basically, you're using it in combinations with topicals and biologics and oral medications and things like that. So it does not have to be used in isolation. There are 3 dedicated codes for psoriasis, as you can see here, that vary based on body surface area. And then there's codes from STRATA that coincide with those 3 levels of surface area codes. Notice there's also a 96999. It is trying to be moved that these 3 codes are specific to excimer laser, XTRAC laser, so that we can use them for everything in addition to psoriasis. But as of now, some of our vitiligo patients are being coded as 96 and 999s. Most of our psoriasis and atopic derm are falling under those 3 codes, though, 20, 21, and 22, which makes it easier. There is a reimbursement support program, and this is through this online RDX portal. This is actually very important for your practice because your nurses or who's ever doing this will load the information for what you would normally do the prior auth into the system with the demographics and what the patient has failed and body surface area and things like that. And then STRATA actually does the prior authorization, which saves you a lot of staff time, effort, and money in that respect. And then they are very good and quick about turning that back around so that you can start patients on treatment quickly. Taking the burden of prior auth off of my staff was actually a very big thing for us and made this one of the reasons why this was more attractive than just having an excimer laser that you have to worry about doing all the work for yourself. However, it is more than just doing the prior auth. The partnership program that the XTRAC program from STRATA offers is very robust. Practice development support is important. It helps get your practice up and running with this device and supports it through and through. They also do marketing and things like that to drive patients to your practice and will help your practice market internally as well. The patient rebate coupon is very big. It has been nice that the patients have to do a minimum number of treatments and then get their copays refunded. That's actually important because it encourages compliance with the therapy. And this makes the treatment very affordable for patients who otherwise might balk at a $40 or $50 if they have a specialist copay per treatment. Now, some plans don't have that, but some insurance plans do. And that rebate coupon there makes it affordable for all my patients. Field support service is very important. If your device has a problem or needs to be serviced, you want that done quickly because you don't want downtime. You don't want to interrupt your treatment courses with patients, and also it's lost revenue for your practice as well. So it is important for both patients and practice to keep those running. If there is ever a problem with the device, STRATA does send a team out very quickly to fix the device or do gas exchanges or whatever is necessary to make sure those devices are running. Normally, if you own your own lasers, when things, become obsolete or a new device comes out, you're not worrying about having to pay for a new device, including maybe if your previous one isn't paid off. Here, if new machines or technology comes out, STRATA places those in your office quickly. I think we're on our 3rd or 4th laser right now in generation here since we started in 2017. Clearly, the new ones are superior to the ones we had back when we started. And it's nice that I don't have to factor out how I'm paying for these things because it's just included with the program. I mentioned the DTC before. They do run these that drives patients to your office. The reimbursement support is really important because they're doing the prior auths, and quite honestly, they turn them around quicker than we could do so because their staff is so expert at doing these. And then that final one there, which is really big, clinical support and training. They are the ones coming in and training the staff who are doing this. So in my case, they are coming in to train my nurses how to operate the device. Now we've had some pretty good stability with nurses, but right during the pandemic time and immediately thereafter, we had some nurses coming and going. So it was actually really great that they were willing to come out here and train that staff every time that we had a new nurse hired. So they made sure that they were very good and efficient at firing the device. So who exactly are the ideal patients here? Well, it's indicated, as I mentioned, for psoriasis, vitiligo, and atopic dermatitis. For psoriasis, you've got some of these tough areas, even in people who are on topicals or even biologics that work pretty well overall. Sometimes we see issues with scalp, those thick plaques on elbows and knees. Palmoplantar is a really tough one. It's probably the hardest to treat of all the forms of psoriasis that we have. Even patients who are on biologics often have breakouts of palmoplantar psoriasis. And nail disease is tough. And oftentimes before we had this, we were reaching for methotrexate or a biologic just to control nail disease. And now I don't have to do that anymore. I can have topicals for other areas. And if it's nail disease, I can use my XTRAC laser. Or the flip side of the coin, I have a patient who we have on a biologic in other areas, particularly, their skin and elbows and knees and things may clear up, but their nails only get a partial clearance. And then I can use my excimer laser to clear their nails. And patients really love to see how well their nails do with this. It's painless and it's easy. And it's a whole lot easier and a whole lot nicer for patients than trying to do intralesional Kenalog into nail beds, which is, kind of old and barbaric, versus this technique, which is completely painless and much more high tech. Also works really well for ears and nape of neck. Scalp, I want to go back to that one too, because you can kind of comb layer by layer, and they will train your nurses how to do this very effectively to make sure that you're treating the scalp efficiently, even with moving the hair. And honestly, we've seen really, really nice results with this, which is tough on patients oftentimes and leads to escalation to biologic therapy, even when they may not want it or need it, simply because we can't get their scalp disease under control with many of the topical meds we have today, or those treatments are just flat out too messy. So some of our skin of color patients in particular who don't wash their hair frequently and don't like to put topicals in their hair really do love this device. For vitiligo, it can be used anywhere in the body, but obviously we know over bony prominences, it's kind of hard to treat. Hands and feet and elbows and knees don't respond as well. It works particularly well for face, neck, and upper chest and some of the fleshier areas on the abdomen. Most of our patients probably have their primary concern centered around face and neck because those are the very visible, particularly our skin of color patients. And this becomes an extremely effective treatment. We often combine it with Opzelura, where we can get that approved because that combination seems to be very, very powerful. And as of now, remains probably the best of what we can offer those patients. Atopic dermatitis patients really benefit from the quick itch improvements that they see with this. Elbows, knees, some of those more like kinified areas that you see on arms and things like that can improve very well, particularly on the palms and soles and neck. So this becomes something that we add to a lot of other treatments we do. But with atopic derm, clearly we're not using this in isolation. We're using it with other treatments such as topicals and even Dupixent and other biologics, or even JAK inhibitors. Again, you're looking at about treating about 10% body surface area max at a time. So, if somebody's got a very high body surface area, this is not going to be your only treatment. However, it does make for a very good conjunctive treatment that you can use with biologics while you're waiting for those insurance benefits. Because remember, this prior auth is going to be turned around very quickly by STRATA through that RDX portal. Or even in patients who are on biologics who have flare-ups at this time of the year in the Northeast as winter sets in, oftentimes we don't change their biologic therapy. If they have that little bit of a flare-up, we can just use this to clean that up. And obviously topicals, a lot of patients don't want to be married to their topicals, or topicals are just not enough. Same thing with phototherapy, which is a lot weaker. Those things may help, but they're just not enough to get patients clear. And instead of being satisfied with, the PASI 90 or PASI 75 or EASI 75 or EASI 90, this helps my patients to get closer to 100% clear, because those smaller resistant areas, I can use this device to clean up. So the other thing that, comes to mind with this is that there are a set of patients who don't have a lot of therapeutic options, such as immunosuppressed patients, pregnant and lactating women, or pediatric patients whose FDA-approved therapeutics are much, much smaller. So for those patients, this becomes one of our main go-to treatments. Children tolerate it very well. It works very effectively in pregnant and lactating women, and really nice for immunocompromised patients where we don't want to risk putting them on biologics that can further suppress their immune system. Clearly, it's not in isolation ideal for generalized disease, erythrodermic psoriasis, photosensitivity disorders, or for your patients who can't commit to coming in, 2 times a week or so for the therapy. I do have some patients who live far away, in an hour or 2 away, and this just does not become practical for them. But, most of my patients are probably under half an hour from my office, and that seems to be a very reasonable time frame for them to consider coming in for the treatment. Obviously, some of my vitiligo patients, even though those involve more treatment, actually sometimes seem more willing to come in, because if you have facial vitiligo and only have Opzelura as an option, patients are really willing to try hard for that, and even sometimes make the drive a little bit farther, even for their 20 treatments, let's say. So don't necessarily prejudge what distance you think is reasonable, because we've even had patients come from an hour away before because they really like the result, and they may work in the area or are willing to make that drive. So even with winter, I've had patients come in from farther out. So you can still introduce it to them, but be aware that sometimes if it gets really far out, they may not want to make that drive to your office. So the benefit of a 308 excimer laser really is shown in this graph here. You can see here, this is a wavelength of light that is very effective at targeting those cells, those immune cells in the skin, to cause the apoptosis of T cells that are attacking the skin there. It's a very high intensity, low band UVB source, and it is very safe at introducing T cell apoptosis, but not damaging other cells and not increasing risk of skin cancer. So a couple of other things that kind of go along with this here. You can see here the psoriasis clinical trial protocol here. About 6.2 treatments are needed to get to a PASI 75. So you can see what that looks like. Again, it is working mainly by introducing apoptosis to T cells and to some of those hypertrophic, basically, keratinocytes that are in those layers there. This is a picture of a vitiligo patient that got 75% repigmentation in less than 20 treatments. So remember, vitiligo is going to be slower. It is going to take more treatments, maybe 6 to 10 treatments for a psoriasis patient, and about 20 treatments for a vitiligo patient. So make sure they understand it's a bit more of a commitment. However, the flip side of the coin on this is, normally if you do a topical therapy alone, such as Opzelura or a TCI inhibitor or something on a face, even after they repigment, the chance of a flare-up is pretty high, and those areas often recur or they get new areas. On the other hand, with excimer laser, no pigment loss is generally observed within a 2-year follow-up, and 80% facial repigmentation is retained at 3 years. So if they get the color back, they tend to maintain it there and don't tend to have relapses in the same spot, which definitely separates this from our topical therapies. Atopic dermatitis here, you can see, kind of falls within the middle. Generally, these patients need a few more treatments than your psoriasis patient, but it does work very well. You can see here about an 81% reduction in itching within 4 weeks. Many patients see an itch reduction after just 2 to 4 treatments to start with, but obviously that itch reduction gets better as you go. You can see what this looks like after 7 treatments. And again here, if you do use this on things like, palmoplantar dyshydrotic eczema, you can see long periods of disease remission, even up to 2 years plus, which is very different than we see with our topical therapies, where patients tend to flare up quite quickly. So very safe and minimal side effects. Blistering is something I definitely like to talk about with patients when we discuss it, because it is a normal side effect, and it can happen. And we don't actually mind if it does happen. Obviously, we're not trying to cause severe blistering or anything like that, but it is a normal side effect and often leads to faster clearance. So as long as we kind of, coach patients on that ahead of time, they don't seem to mind and they're not scared if they do see a blister. If you don't mention it, it can be scary to see blisters. You think you got burned by the laser and that your, skin is going to be worse from it. But I think it's nice to come out in front of it and tell them that, yeah, you may see a blister or two, and quite honestly, it might actually lead you to get clearer faster. Hyperpigmentation and post-inflammatory hyperpigmentation are very real. That does fade over time, and it is safe for use in children, as I said, in pregnant and lactating women, in people who are on immunotherapy. And overall, it's a lower cumulative dose than other phototherapies. You're only targeting affected skin, not treating an entire body like a UVB light box. And there is no increased risk of skin cancer has been shown in long-term studies. So a couple of things here to keep in mind. It is very important to get the starting dose correct and to get up to that optimal treating dose and increase accordingly. You don't want to be too conservative, because if you do, you're not going to get the outcomes that we're trying to shoot for here, or that your patients want. It's only going to delay therapy. It's going to need more therapies, and you're going to get patients dropping out of treatment. And drop treatments or patients not wanting to do it leads to less revenue for your practice as well. So use the correct appropriate dose, increase the dose according to the guidelines as much as optimal. Optimal dosing really means a consistent moderate sunburn reaction. So you're looking for that mild tenderness erythema lasting 1 to 2 days. You should do 2 to 3 treatments a week. Most of my patients do twice a week, at least one day in between, and then increase those dose percentages following the algorithms that your team is provided with. Patient education is really critical. As I said, you need to tell them what you're aiming for, and that blistering is a common side effect and often leads to a better outcome. Make sure that patients are really committing to 2 times a week here, because if they're just doing one treatment here and there, it's not going to really work and compliance drops. We do try and book multiple appointments at a time, just this way they're in the books, and patients are not like calling or playing phone tag to get further treatments scheduled. So the nurse does the treatment, the nurse books the next series of treatments, so they're already in the book and the patient's all ready to go. Technique is important, and I feel like the STRATA team teaches my nurses how to do this very well. The handpiece needs to stay in full contact with the skin. You want kind of like a uniform lawnmower pattern to avoid any overlap or underlap. And then utilize the templates to treat various shapes and protect healthy tissue from the treatment, because you really only want to treat lesional skin, not the surrounding normal skin around there. So a couple of treatment pearls with this. This needs to be recommended ideally to every psoriasis, vitiligo, and atopic patient who comes in your doors. And remember, this is a large number of patients. There's 10 million people who have these diseases in the United States. This becomes a really great treatment. We have some people who don't want to go on systemic medication. So, cream plus XTRAC becomes their mainstay. We have other people on biologics, where we use this either as we're waiting for those biologics to get approved, or as a cleanup tool where the biologic works, just there's a few stubborn areas, or, we see at this time of the year as the weather sets in and stuff like that. They're clear most of the year, but they get those little flare-ups around November. And sometimes in the spring, as the weather's fluctuating, I can use this laser to take care of those areas. The nice thing is generally the prior authorizations are good for a year. So sometimes we see these patients in, January, February, March, when they're getting little flare-ups as weather changes occur. They do well throughout summer, and then, they start to flare in October, November, and we need to do a few more treatments to clear things up. So have this available to them. It is worth it, I think, for all of those patients, whether it's vitiligo, atopic derm, or, of course, psoriasis, which is probably our main one that we're using it for. Provide the relevant XTRAC brochure. Patients love these brochures. They like to see the pictures. They like to understand what to expect. They like to know the name of it. They will go home and do their own research. I do feel that patients who get these brochures definitely tend to want the treatment and are happy to talk about the treatment with family members and things, who are always universally happy that it's not a medication, it's not a steroid, and it's not an immunosuppressant. It's not an injectable agent where they may be afraid of a biologic, or if they're already on a biologic, adding something else to it. Light energy that doesn't cause cancer makes people happy. Submit it to their insurance company through this RDX portal. Patients qualify. We have very good coverage in our area for psoriasis and atopic derm. Coverage when I started for vitiligo actually used to be pretty poor, but now actually is pretty darn good. So we do get a lot of our vitiligo patients covered for this. Some insurance companies will limit it to like sort of visible areas like face, neck, and hands. But for most patients, quite honestly, those are the main areas they care to treat anyway. Some insurances will cover it for any location. But again, even in those cases, it's probably not going to work great for the bony prominences like, knees and elbows. And then as soon as patients are approved and your nurses see this RDX portal, it is really important to get them scheduled for that first treatment right away. You don't want to lose momentum. And after you get it approved, you want to jump on it and really start treating. When they come in for that first visit and we go through everything with them and do the first treatment, my nurses are booking like the next bunch of treatments for the treatment series. So they're already booking 6 to 10 treatments at that time. This way patients block their calendars. They're ready to go. They know a time and can do that. You don't want them calling and saying, hey, I can only make it between 4 and 5, and all those appointments are taken. And now you've done a few treatments and they can't finish the series and they get frustrated. And if they haven't finished a certain number of treatments, now they're not getting their copays back. So try and really book those at one time when they come in for that first treatment, because that really increases compliance and it actually makes things a lot easier on your staff so that they're not wasting time playing phone tag with these people to get them back in. So key talking points here at the end of the day: this is a painless, safe, highly effective treatment. There is no downtime. Patients, oftentimes from some of our school-age kids and stuff like that, they're coming in after school, they're getting their treatment really quick, and they're going right back out to their sports practices and things like that. So absolutely no downtime or limitations. 2 to 3 sessions a week. I will tell you the average patient in our practice really is coming in twice a week. It's kind of hard to get people back 3 times a week. Generally really well covered by insurance, particularly for psoriasis and atopic derm, but coverage lately has really increased for vitiligo. The copay rebate program is available for your patients who do have a copay, and it does actually help compliance because they do need to complete a certain number of treatments to be eligible to get that copay back. So ever since STRATA has changed to that model, it's actually really helped our compliance to get people to come in for that series, and ultimately really increases patient satisfaction, because if they do those 6 to 10 treatments for, psoriasis or atopic derm, they're actually going to see a huge benefit. And as I showed you from those slides earlier, it's a lasting benefit. People stay clear for 2 years plus sometimes in those areas, as opposed to a cream where they might just flare up. And we know vitiligo patients are going to take a little bit more treatment. So make sure they understand that before they start, that it is probably going to be about 20 treatments to really get a more complete result. You're going to see results before that, but it's not going to be something that makes them happy until you probably get to around 15 to 20. You do use it alongside other therapies like topicals, orals, and narrowband UVB. Targets only affected skin, leaves the normal skin alone. And again, safe for immunocompromised patients, children, pregnant, breastfeeding women, and all skin types. So looking at psoriasis patients here, 6 to 10 treatments is going to be roughly what they're targeting to see significant clearance. 10 to 20 treatments for full clearance, and the results last 6 months plus. A lot of these patients are remaining totally clear in the areas that you treated. Obviously, if they get a new area, you can always go ahead and treat that too, so that they get clear quickly there. With vitiligo patients, this really remains the gold standard, particularly when combined with Opzelura. We get really nice results with that. Works best on the face and neck. You can use it in other areas, chest, and fleshier areas of the abdomen work quite well, or even the thighs. Not so good over bony prominences, so elbows, knees, the, fingers and the joints there, probably not going to be the ideal treatment for that. And then atopic dermatitis patients are going to see itch improvement pretty quickly, very statistically significant by 4 weeks, noticeable reduction in redness and skin thickening within 1 to 2 weeks. So it really does help those lichenified areas that we sometimes see on, like wrists, antecubital and popliteal fossa, or for dyshydrotic patients on hands and feet, where this works extremely well. And that is all I have for you guys tonight. I would love to take questions if you have them about anything related to the treatment or the financials of how this works.
Thank you, Dr. Nazareth. That was incredibly insightful. Like Dr. Nazareth said, we're going to open it up for questions. So if you haven't already, feel free to submit your questions using the Q&A feature at the bottom of the Zoom screen. We've already got a couple in here so far. Here's one. Are there any areas that you can't treat?
We do treat all areas. You got to be a little bit careful sometimes with eyelids and things like that. But overall, we get some very, very good results in all treatment areas. I would say that probably the most common areas we're treating, obviously, for psoriasis, we do a lot of palmoplantar, nails, and scalp are probably our main areas for that. Atopic derm, I would say, antecubital, popliteal, neck, and palmoplantar, again, for dyshydrotic are probably our main areas for there. And for vitiligo, we do a lot of face. The one area I really didn't talk about much, which I think is important, and this question raises it, this is really effective for inverse psoriasis and genital skin too, as well, for both vitiligo and for psoriasis. So we do those treatments to those areas, and it is very effective for genital skin, and patients tolerate it well.
Okay. How often are you seeing a patient for follow-up if the nurse is doing the treatment, and when do you decide to discontinue?
So good question. We generally continue with our normal treatment. So basically, if somebody's flaring, let's take an example. If I have an atopic or a psoriasis patient that is on other therapies, including biologics, maybe flaring, we start the treatment. I'm probably going to see them back in about 2 months, because at that point they've been through a bunch of the treatments. Sometimes I'll poke my head in if they have a question or something along the way. The nurses are good at picking up on that. But in general, we're kind of keeping our normal treatment schedule. Now, that being said, I've got a few patients who are, my normal long-time psoriasis patients. They've been on their Skyrizi or their Cosentyx or something for many years. They know they have these little flare-ups around wintertime every year. We get them on the XTRAC, they get their normally scheduled thing, and I'm still only seeing them, every 6 months or a year or something like that. I don't necessarily have to see them an extra time if they know we're just going to clean it up with that. It is important, obviously, with your psoriasis and atopic patients and vitiligo patients that you're still doing their regular care, so you don't want to miss their skin checks and things like that. But we don't have any issue of bringing them in for their normal visits and basically keeping that normal cadence of what you would do to manage your patients. Because remember, the nurses aren't managing the prescriptions and things like that. They're solely delivering the therapy and they're not providers. I know in other states might be a little bit different depending on who you're delegating to do the treatments, but with New York State, it has to be a nurse and the providers are going to see the patients as they need to, as usual. It really doesn't interfere with that.
Gotcha. This next one, do you worry about any photosensitizing medications?
No, we don't have much issue with that because it's delivering it so precisely to the plaques themselves. And obviously we're adjusting based on what we see. So, if somebody is a little bit more sensitized or something like that, or gets a little bit more exuberant reactions, we're going to adjust the dose accordingly. And there's very good algorithms that's easy for the nurses to follow on that. To me, this is a big advantage over narrowband UVB, where you're exposing someone's entire body to light. And you're getting a low level of treatment in all areas, including most areas that probably don't need it. And here we can deliver very high energy to just the affected areas. So I don't need to worry as much about, patients with photosensitizing reactions or different medications and things like that. It makes it easier for our providers too.
Perfect. How do you determine the XTRAC is the right modality when there's so many additional options for psoriasis patients?
I actually see that as an opportunity. There has been a lot more treatments, for example, for psoriasis and atopic dermatitis, particularly atopic derm probably, that have come on the market since we started using XTRAC in 2017. And it's actually led to an increase in usage in my office because, as I said, we are not doing this as a sole treatment in most cases. This really is adjunctive and conjunctive, I would say. In almost all the cases we're using it. I think there was a concern early on, like, if patients are on biologics, now that these newer biologics are getting people to PASI 90 so well, are we going to need to use this machine? And what we found is that patients and providers, I think, and rightly so, we've gotten kind of greedier or higher in our expectations. When we had Humira back in the day, we were so excited when we got a patient to PASI 75, and even if they still had about 25% left, we're like, wow, you're so much better. And now, we're expecting PASI 90 and 100. When people have these little flare-ups, they call right away and they're like, my psoriasis is coming back. What do I do? And now I have a treatment for that. Before, you're like, oh, just increase your topicals, or maybe we'll do something else. Some patients want to change their biologic over that. This gives us a really good opportunity to take those small flare-ups and quell them very quickly, but also in a lasting manner. Because it's easy to tell a patient, here's a script and just use this cream. But chances are compliance with the cream falls off, number one. And number two, if they stop using the cream, spot's going to probably re-flare and they're going to be calling you again. Here we've got a great treatment, cleans up those areas, gives them long-lasting remission in those areas. And in the process, we're getting a financial benefit to the practice rather than fielding a whole nother stream of calls every 2 weeks when, you send a topical, they try it, it doesn't work. You send the topical back, you do a different one. You're just kind of bouncing back and forth. Whereas here, the treatment works, cleans up those areas, and they're happy.
Perfect. Can you walk through your treatment protocol when you're using XTRAC conjunctively with biologics for psoriasis patients?
Yeah, I really look at it as two ways here. Number one, there's some patients who are new to us who are coming in who have significant disease. Actually happened today. We saw a pretty significant psoriasis patient. I'm going to be starting them on a 17 inhibitor because they're exhibiting some joint symptoms as well. However, I know that, I'm submitting all this authorization paperwork. It's going to take them a little while to get that approved. An average biologic, I would say, in my practice is probably about a 2-week turnaround time behind we actually get that thing approved. And then we like to do the first injection in the office, and the patient's got to get scheduled and come in for that. We also input the data today into RDX for XTRAC approval because they've already been on topicals from their primary care physician. So we're going to be able to get that approved much, much quicker. So we'll start them probably on XTRAC therapy before we get the biologic approved. On the other hand, we've also had patients probably last week that we saw here who've been on biologics. I'm going to point to, a couple of atopic derm patients in particular who are now flaring with this time of the year, a little bit of palmoplantar disease, with their dyshydrotic component flaring up, or some of those younger kids who are doing pretty well, but are getting those little bit of flare-ups on their antecubital popliteal fossa or neck. And now we can just kind of get them engaged in XTRAC to clean up those little bits of flare-ups. So yes, you can do it as something that you're starting with, or you can do it as something that you're doing while somebody's treating. Or the final one is that people have been doing really well, haven't needed anything. They're stuck on their biologic for a long time, and now they have a little bit of a flare-up, but they really like the biologic that they're on. So before you consider switching, go ahead and try XTRAC to clean up those areas, because unlike a cream, you're going to get that long-term clearance at the spot. So if it's a small body surface area, go ahead, use the XTRAC laser, clean it up, and they might stay clear for 6, 12, even 24 months.
How do you motivate patients to keep coming back to the office for treatment 2 times per week?
So I think it starts with nurses. I think my nurses do a really good job of following our practice protocol, where you got to get them in for that first visit. And when they're there for the first visit and you're going into it, they're preaching the compliance that you really do have to do, and set the reasonable number expectation. We're talking 6 to 10 automatically with a psoriasis patient. We're talking about 10 with an atopic derm patient. We're talking about 20 with a vitiligo patient. Set that expectation. It's not a surprise thing like, oh, let's just do 2 more. You really want to get them to commit ahead of time and book those appointments. I really think that's the key. If you book those appointments, patients come in for them. If you say, oh, we'll call you, or what, we're going to book this appointment, the next one, and then, I'll call you after that. That leads to a lot of phone tag and a lot of decreased compliance, I think, at that point. The other thing that's really increased compliance is the way STRATA has now done the copay assistance program. Patients do need to do a minimum number of treatments in order to be eligible for that. Now, obviously, not all my patients have copays, so it's important for your nurses to do that job too. Do not rely on the copay assistance program, but it acts as like a second thing to support what we're trying to accomplish here. So for my patients that do have a copay, they know that they need to complete X number of treatments in order to file that form to get their copays back, which again really does increase compliance. I feel this is the biggest kind of lift for the vitiligo patient, because you really are looking at about 20 treatments. But the good news is, even while you're looking for 20, even 25 treatments to get a really, really good result, they're seeing results sometimes after 6, 7, 8 treatments. So the fact that they're seeing results is like a self-motivator. And, you can have your nurses talk that up like, wow, look at this. We take a ton of pictures. And pictures really help, because you just have somebody tell you, wow, it looks better. They're gonna be like, yeah, sure, it looks better. But if you can show them like, wow, this is what you look like before you started, and here, you've done 5 treatments, and these are the areas that have gotten better, and maybe there's some that haven't, now that motivates them to continue, because they see success, and obviously success breeds more success. So use pictures. The nurses training, I think, is really critical. Get those appointments booked and take advantage of the copay assistance program, because that in and of itself will also increase compliance.
Have you been combining topical JAK inhibitors like Opzelura with the XTRAC?
Yes, in all cases where we can get it approved, we would prefer that 100% of our patients on vitiligo obviously would ideally be Opzelura plus XTRAC. But obviously, we do have a lot of patients on Opzelura plus some other therapeutics, obviously, for atopic derm. And then obviously for psoriasis, we're combining it with Vtama, Zoryve, topical steroids, TCIs, etc. All very effectively. But yes, you can use it in conjunction. I know there's that limitation on Opzelura where you cannot use it with a biologic medication. However, this can be combined with all medications. I'm going to bring up one thing, actually, Rob, that was asked to me very astutely at the last one there too, is that if you have somebody where you're thinking biologics are already on a biologic and maybe needs a re-up, will, doing a prior auth and having them on XTRAC interfere with your ability to get the biologic approved? And the answer to that, thankfully, is no. It is a perfect adjunctive therapy, and we have not had any issues with, if we've already got somebody on XTRAC, then getting a biologic approved, or vice versa, that we have somebody on a biologic and then try to submit for XTRAC and not getting it approved. So they seem to cover that very well. Very oddly, in some cases, we have some insurances that will cover XTRAC for vitiligo, even though they will say that Opzelura is cosmetic. So we seem to have better coverage for vitiligo for XTRAC than for Opzelura in my neck of the woods at the moment, just by the way things are. So I know every insurance milieu for your practices are different, but right now our coverage for Opzelura for vitiligo isn't the greatest, but our coverage for XTRAC for vitiligo seems to be increasing quite nicely. And I think that's a testament to STRATA's team for doing a lot of groundwork on making that happen.
Right. Any guidance on steps to get insurance to cover the XTRAC for atopic derm?
Document everything that you possibly can. We find that, clearly documenting what people have failed, documenting facial involvement or high, wear areas, like if there's hands and arms and things like that, seems to mean more. Sometimes, particularly on people and kids who are on topicals, saying, statements that, if I can't get this approved, or if I don't have another option, I'm going to have to go to a biologic. So insurance companies seem to, particularly for kids who, parents don't want to have to commit to Dupixent if they don't have to, and deal with needles and injections and stuff. So sometimes kids need more than just a topical. And this becomes something great. And insurance companies, when they see that your next move is going to be a biologic, are often more than happy to approve this, to kind of head that off. But in general, I would say that our coverage has gotten a lot better for this. Originally, our coverage was superb for psoriasis, and it was a little bit more of a struggle for atopic and vitiligo. And that's really opened up, I would say, since the pandemic in particular. I would still say vitiligo is probably the hardest of all of them, but our coverage for atopic has gotten particularly good, especially for adults too, when we get some flare-ups with palmoplantar for dyshydrotic and things like that. Because, to me, if you're even on Dupixent and you get palmoplantar, or you're on now some of the JAK inhibitors, or obviously now we have Nemluvio and Ebglyss and Adbry and things like that, sometimes we still get palmar flaring in our patients in wintertime, or some of my, surgeons and stuff like that who've had, constant issues because they're scrubbing and in gloves and sweating in their gloves and things like that. And it's nice to have this as an adjunctive therapy to that. And coverage has actually been pretty good if you can document what they've failed and how it impacts their job.
Perfect. After how many treatments should the XTRAC be discontinued if no improvements with vitiligo versus psoriasis?
So clearly, my threshold for psoriasis is going to be lower. I'm looking probably at, if somebody's getting nothing by 10 to 12 treatments with psoriasis, I'm probably going to be like, okay, this is probably not going to respond. Thankfully, I don't really see that. Clearly, not everybody gets 100% response, but it's very rare that we discontinue because we're not getting a response. Now, vitiligo, on the other hand, I'm really looking at least 20 to 25 treatments before I would give up on using that. Again, we don't really see failures on the face. We don't necessarily get 100% clearance on the face, but we see really, really good results with that. Where we do sometimes get into patients actually asking if they can keep coming and stuff like that is where, you're on treatment number 35 or 40 for a vitiligo patient. Their face is clear, their chest is pretty good. They might have 1 or 2 spots left on a neck or a fleshy area of the abdomen, but they really want to try working on like the elbows and like the hands or something like that. So, judgment call at that point. Personally, if I don't feel like it's really making any change in those, we'll tell the patients, hey, this is probably not, even if you come for another 30 treatments, it's probably not going to do much for your elbows or your knees or your dorsal fingers there. But, as a general rule of thumb, I would say about 10, at least with psoriasis, maybe, 12 to 15 with atopic derm, and 20 with vitiligo before I would consider discontinuation if they're not getting anything.
Got it. Does it work for nail psoriasis?
Very well. I would say that this is becoming has become our go-to treatment for nails and for inverse, and for, those really thick plaques on scalps where, treatments are kind of tough for those areas. Topicals are messy and don't work. We are certainly not doing intralesional Kenalog injections into nail beds. And I don't really want to necessarily take somebody who, had for example, we had a carpenter and he had a little psoriasis on his elbows and knees. It wasn't that bad, and some palmar plantar too, but his biggest complaint was his nails because it was really interfering with his job. And normally my first move there is at that point, I'm reaching for methotrexate or a biologic. But here I didn't have to because I could use the, excimer laser to clear up his fingernails in addition to working on the small spots on his elbows and knees and palmar plantar. But I will say the nails took the longest to clear compared to the other areas. But, he was already seeing improvements and he was very happy with that.
Great. Do you use it for MF or CTCL? And have you seen it covered by insurance?
We are not currently using for that. I know that other people have attempted that, but I think that is something that we haven't even tried to get covered by insurance. A lot of those patients we're referring out in my practice, I can honestly say we don't see a lot of those in my neck of the woods because more of those end up going to Roswell Park where there's specialty clinics for MF CTCL.
Perfect. Do you taper patients off of the XTRAC?
So generally we don't necessarily taper per se. We are kind of treating the areas that remain. So I would say that treatment tapers itself in essence because areas are clearing and you're only continuing to treat the areas that are still sort of remaining. So we do have a lot of patients who may start, remember how those codes are C1, C2, C3 or 96920, 2122. We have a lot of patients that may start with that top level and high level of surface area. And as the treatments progress, become, lower and lower surface area until they're down to some very small areas. Psoriasis patients in a lot of cases, the last areas we're treating probably are the nails and maybe all those other areas are cleared up. But it kind of, I guess, in terms of that works as a natural taper. We're not actively trying to taper it out.
Perfect. Additional questions? Right. Dr. Nazareth, thank you again. And to everyone who joined, thank you for joining us. We hope this session gave you a helpful look at how the XTRAC can not only improve clinical outcomes for your patients, but also create meaningful impact within your practice and how STRATA is there as a partner with you along the way. If you have any additional questions or like to learn more, please don't hesitate to reach out to your territory manager. They'd be happy to take you through the next steps with XTRAC. That said, thank you all again and have a great night.
Thank you. Obviously, if there's questions, your territory managers can always reach out to me too. So if there's other questions for me that come up, I'm always happy to take those. Thanks, guys.
Appreciate you. Thank you.